Good morning, everyone. Dr. Kassam is away this morning, so I have the privilege of opening grand rounds. I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose histories, languages, and cultures continue to enrich our vibrant community. I will introduce our two speakers. The first is Dr. Darren Lau, who is an academic general internal medicine physician at University of Alberta at Edmonton Clinic. He recently had a challenging patient experience with MAID and is looking forward to Dr. Sookram's insights and advice on the case. And Dr. Sunil Sookram is one of our valued emergency physicians here at the University Hospital, a military veteran and medical leader. He currently works clinically at the University of Alberta Emergency Department and at the Garrison Edmonton Health Clinic. He holds a number of administrative roles, including medical consultant to Alberta's Health Insurance Plan branch and medical lead for MAID in Edmonton North. He has previously been facility medical director for the Northeast Health Center and Strathcona Standalone Emergency, STARS Grand Prairie-based medical director, provincial EMS medical director, and Edmonton EMS medical director. Career highlights include military deployments to Bosnia, serving on the critical care aeromedical evacuation team during the war in Afghanistan, and helping set up and leading the medical team at Strathcona Hospital. Dr. Sookram has been involved in MAID since its Canadian legislative approval in 2016. He hopes to highlight the MAID approval process, some of the growing complexities in meeting patients' MAID requests, and highlighting where MAID is potentially heading in Canada. So, Dr. Lau.
Hey, thanks for that introduction, Dr. Ringrose. My name is Darren. I think you all know me. I'm one of your internal medicine colleagues at the university here. And today I'm just the opener. I'm just here to talk about a particularly challenging case I encountered in hospital, one where the outcome was suboptimal, shall we say. And this is the case that provides the impetus for having this talk today. And I'm really hopeful that collectively we can all maybe learn something from the case, but definitely learn something from Dr. Sookram as to how we might prevent outcomes like the one I'm going to describe. Okay, so without any further ado, here's the case. Oops. Let this happen. Just a little one. Much ado about nothing. Okay, so this is an 81-year-old female with metastatic small cell lung cancer, diagnosed with bony metastases, and she underwent 4 cycles of chemotherapy and then was placed on a checkpoint inhibitor therapy, so immune therapy for maintenance. Her last cross-cancer visit on darvalimab, the oncologist had noticed on the CT scan some subtle liver nodules, but it wasn't clear that these were metastases versus darvalimab-induced liver inflammation. Overall, the notes said she was doing quite well. Later, she presented to a rural hospital near where she lived with the nonspecific symptoms shown here, and the CT scan showed markedly increased size and number of liver lesions. She was mildly hypoxemic. She had significant elevation in liver enzymes. Bilirubin was almost normal. And she had quite a low platelet count of 7, mild anemia. She had an acute kidney injury. The working diagnoses at the time were liver metastases, possible superimposed darvalimab-related liver injury for those liver enzymes, darvalimab-induced ITP, and a pneumonia versus pneumonitis related to the immune therapy. She was transferred to the university and was started on ceftriaxone, azithromycin, IVIG, dexamethasone, and IV fluids for the acute kidney injury. She was admitted on a Wednesday evening, and as always, this hospital was stuffed to the gills, so she never made her way to one of the 5D units. She was admitted to an off-service unit with goals of care being M1 at the time. I saw her on Thursday morning, and at the time she was stable, comfortable, very alert, looked pretty good clinically. And right up front, she volunteered that, look, at the end of things, I want MAID. She was very upfront about that. And she'd been told at her last cross visit that all she needed to do was request it and it would be given to her. And she had made no other preparations for MAID. seeing how stable she was, the thought here was, all right, you look really good, and maybe you should pursue MAID, but maybe at your home hospital, be closer to home, be closer to family. So my thinking here was that we should continue medical therapy to try to make her better, resolve some of these biochemical abnormalities, and then repatriate her. And she was agreeable to that plan. But I provided her and her family with the record of request form to get the process started. The next morning I saw her and she was very tired now, so looking a little bit more tired, but continued to reaffirm her desire for MAID. Having said that, despite a couple of family members present, no progress had been made on the record of request form. So I ended up assisting with that form. I filled the role of the independent witness, and I went through that form with her and we filled it out together, and it was somewhat laborious, but we managed to fax that form over to the MAID office in the afternoon. Saturday rolls around and she was noted to have delirium overnight, and the biochemical and hematologic abnormalities hadn't responded to therapy at all. And then Sunday rolled around and overnight she had an episode of severe generalized pain. All this stuff tended to happen overnight when I wasn't around, which was very challenging. Now in the morning, she was pain-free, looked well from a vital perspective, but she was confused and fatigued and clearly deteriorating. So at this point with her family, we changed the goals to C1 and we initiated therapy with haloperidol and hydromorphone, PRNs, and that afternoon we escalated them. Then the wee hours of Monday morning rolls around and she has a severe pain crisis. It's accompanied by hyperactive, agitated delirium, and she was crying out for her own mother. The nurses provided PRNs, did not find them effective. They called the family. The nursing team themselves were fairly anxious about her. And the patient's daughter rushed to the bedside, was able to settle her down, and shortly afterwards, the patient passed away. When I spoke with the family later that day, they expressed a high degree of distress and anger about the suffering she had experienced prior to passing away, and that MAID had not been provided in hospital. I guess my question here is what could I have done better? But possibly as a system, collectively, what could we do better to avoid outcomes like this? Practical tips, suggestions, maybe even fodder for quality improvement projects. And with that, I'll pass it to Dr. Sookram.
So I think many of you know me. My name is Sunil Sookram. I'm a emergency physician. I unfortunately am the one that has to call you at all hours and give you increased work. On behalf of all my colleagues, I apologize. It's just the nature of our work, but it's a great privilege being here, sharing this information with you. I'm very passionate about this area of medicine, and hopefully we can use this as a moving forward point in improving quality of care of our patients within this hospital and within AHS as a whole. So just some disclosures. I have a 0.2 FTE AHS salary for medical leadership in MAID. I am also 0.5 FTE salary from Alberta Health for my consulting position that was outlined earlier. And 10 years ago, I was involved in pharmaceutical stuff, but not anymore. And today's discussions don't discuss any pharmaceuticals, or only generic names will be used. So the objectives I hope to accomplish today and leave enough time for questions, I think that's the important part, is I want to share with you the enrollment criterion, the processes and documentation, so that if you choose to, you could be more engaged in the process and streamlining eligibility and or still being true to your heart if you are a conscientious objector, how to navigate that part, to share MAID process navigation processes within our Alberta Health Services system, and to highlight current MAID processes and challenges within an in-hospital environment, because we do both in-hospital and community-based MAID care for Edmonton, as well as the entire North Zone as well, all based out of here. So the reality is MAID lies on the spectrum of end-of-life care. And where it lies depends on your values, the individual clinician's values, and ultimately the patient's set of values. And there's conflict sometimes in those two areas meeting. And so how you navigate that is what I'm hoping we'll have a discussion about today. And I'm hoping we'll generate some discussion and conversation that we can all take away something from today. It's a controversial topic. Right? It brings up issues about religion and beliefs. It conjures up emotions. There is an element of Canada that is opposed to it. and are conscientious objectors for whatever reason, and that's fine. We've tried to build a process that respect for conscientious objectors and yet allows those that choose, the patient's values that choose MAID, to be able to proceed if they choose to. I think ultimately, professionally, one needs to remember that the values that are most paramount in this whole big picture is the patient's. It may differ from our own personal values, and I've been challenged too as a MAID supporter. I've faced requests that I disagree with. And how you navigate and how you think about it and how your own personal ethics come into play are important to think about and move forward on. And so this is a very contemplative topic, and it's not right for everybody. And individual cases are not right for individuals. And so we as a MAID coordination team try to match requests based upon patients and clinicians' values, because our team is small. So I think you'll see that exercised in our discussions today. So what is the burden of this? Just to give you some highlights, within Edmonton zone alone in 2023, 318 cases, and it's growing in 2024, 402 cases. And those within the acute care settings, 89, 2023, 24, 93. Now that is skewed a bit. Those that present to our faith-based hospitals, who don't agree with MAID. We carry out the assessments there, but the provisions don't occur in faith-based hospitals. So we conduct forced transfer, unfortunately, to a neutral subacute setting or a neutral location or their home to provide in those settings. So they don't reflect in our numbers with respect to what's happening in the acute care settings. So you can see from this is a growing trend in our healthcare system. And we're seeing, because of informed, educated, and often higher socioeconomic class patients are informing themselves of MAID and choosing it as an end-of-life option. The population is not just that population. It's not mutually exclusive to that. The MAID applicants come from all walks of life and all backgrounds. And likely, as we're seeing, as people awareness is growing and our population is aging, we're going to see a greater awareness and a greater applicant pool, I suspect. People are becoming more informed about this. It's now almost 10 years of MAID in the country. And so people are seeking this out. Whether it's good or bad, people have this vision of what they call a good death, or what they refer to as a good death. And it means a different thing to different people, and people are seeking that out. And legally, they're entitled to that choice. And so we have to figure out a way to accommodate them within our system. So what's involved in this? I just want to throw out some nomenclature. Remember nomenclature from high school chemistry? Well, I like that word. So from a nomenclature standpoint, we throw out these terms and not everyone knows what they mean. So I want to highlight what they are and navigate and help share with you what they mean and what's involved in them. There's a term called the ROR, the record request. I think, Darren, you alluded to that. So we're going to talk a little bit about what's involved in that. This is a patient-initiated document that legally starts the whole process. There are assessments that need to happen. In order for people to be eligible to MAID, they need to have 2 independent assessments done, and what we call an IA, or an independent assessment, and then the provider will carry out another assessment as well. The 2 assessments have to occur without each of them knowing what the disposition is. So they have to be mutually exclusive and independent of each other. And then we'll throw out this term that complicates things a bit, but can have bearing within MAID, especially in a hospital setting, for the picture that you painted, Darren, of fluctuating consciousness and delirium. There's a concept called the waiver of final consent, the WFC. It's not always used, but it is an option to navigate patients that have the situation you describe, and I'll talk about those things. I'll just put it out there. There is a CPSA position on clinicians that choose or may have conscientious objection. There is a standard of practice that exists where, and I quote this from the standard practice, a member must ensure that a patient is offered timely access to a regulated member that can provide the service if they disagree with providing the service, or a resource that will provide information about medical options. And we are fortunate in our jurisdiction that we have a coordination system, a coordination navigation team that will do all of the hard work if you choose to be an objector. And so if you are an objector, it's a matter of referring the patient or their family to the coordination center. And I'll highlight how to do that so that you can maintain your conscientious objection. One could direct patients to their families to the main coordination team to start the process. And the navigation team, we have a very good navigation team. It's well funded and well supported in our system. It'll navigate and guide the patient through the process. It'll liaise with the patients and the family. And if they're having in-hospital MAID, they'll liaise with the patient care manager and the nursing team to get things in order and ensure that the assessments occur by clinicians in a timely fashion. It's a matter of communicating with the navigation team the needs. So if someone is deteriorating at a rapid pace, the trajectory is heading that way, it's a matter of communicating that to our team so that we can try and expedite as much as possible. So let's start with the record of request. It's the formal legal document that allows us to start the process and allows us to carry out the assessments of eligibility. If you are looking for it, and I don't know if you know where to find it, but if you Google AHS and MAID, you get a web page, and if you go under health providers, all the forms and documents are there. The ROR is there. If you want to see a hyperlink, it's there, and I think my presentation will be posted, so you'll have access to it that way as well. But the assessments can't occur until the ROR has been submitted. So any delay in that delays the start of the assessment process. And that's just what the law lays out. So to highlight what the ROR is, it's a big document, but the themes are quite clearly laid out. It's the patient completes this or a proxy. So if the person's unable to sign it, someone can fill it out for them, but there's a place for the proxy there. It highlights what their demographics are and how to contact them. So all important information. It highlights that the eligibility criteria. So the patient acknowledges that they have these conditions, and they sign beside of it acknowledging that they meet the criteria. So they're greater than 18, they know that they can withdraw their request at any time, they are eligible for health services, and that's an important one. We did not want to, when the law was created, to create something like Veritas in Switzerland, where people do medical tourism to come to Canada. So that statement is an important one. It's in the law, and it's one of the eligibility criteria. And that they believe they have a serious incurable disease or disability, that they're in an advanced state of irreversible decline, and that they are suffering in some capacity. And so the patient signs, and then there's the issue of the witness. And I want to highlight this. The witness can't be somebody that benefits from the death of the person, which complicates things in hospital. Right? Because it's family that are visiting them primarily. Likely family are the people that are going to benefit, so they can't be the witness. And on our medical wards, rightly or wrongly, there's a fair amount of spiritual people who are opposed to being part of this process. And as a result, it's sometimes hard to find a witness that's independent. So there are options. The navigation team often will send out a navigator to be a signatory to that as a witness, or there's an organization called Dying with Dignity that will send people to hospitals, care facilities, whatever, to be the independent witness. But all that takes a little bit of time. So in time-dependent area at times, that could be an issue. So the witness is a rate-limiting step sometimes. Submission of the ROR is rate-limiting sometimes. Now, if the person can't physically sign the form, someone can fill it out for them, but is then declared a proxy. The proxy cannot be the witness as well. So there's another person that has to be drawn into the whole big picture and debilitated people. And so the proxy has to acknowledge that they were the proxy and what they did, and that has to be submitted if needed. Proxies are rarely used, but it is an option for people that are debilitated. And then the witness has to sign that they witnessed and were there, and there's some acknowledgements that they have to sign as well. So that whole package needs to be submitted. And then back with the last review, I think in 2021, the Senate in their royal assent process, as part of our legislative process, felt that we didn't have enough data about MAID in Canada and what was happening, what the landscape looked like. So they mandated in the act document outlining us to collect some demographic data so that we can figure out, because all these documents are submitted nationally and collected provincially and then sent nationally cumulatively. So we have demographic data on who is asking for MAID and what their situation is. So this whole package is the ROR. It's often the rate limiting step in getting patients through the process. It needs completion and submission to the navigation team to start the process. And as I identified, witnesses can't be a person that may benefit from the applicant's death, and that the ROR is sent to the MAID coordination team. It currently is not on Connect Care. We are working on getting on Connect Care, all the documents, but currently MAID is not on Connect Care. So you have to fax it or email it. And I'll highlight what those ways are shortly. Once the ROR is submitted, then we proceed with the assessment. 2 independent assessors, the independent assessor or the IA, and the provider. For those that choose to be engaged in this process, the IA can be completed by the attending or a physician involved in care. And I'll highlight what's involved in that if you choose to go to that pathway. You don't need to have certain special training or any designation to be able to do this, right? The IA can be done, and we prefer that it's being done by someone who knows the patient and is aware. So a family doctor is a great option because they know their people. And for some of the patients that are in hospital, some clinicians know the patients, the situation's a lot better and can complete it easily. And so I'll highlight the form shortly. We need to, as part of the process, ensure capacity and ensure that they can give informed consent. We have to, as part of this assessment process, we're going to discuss with families and their patients, the patients themselves, what the processes are, what the alternatives are, and that's an important part of the discussion. People have this misnomer that this is the only option open to them, and there are other options. Good palliative care, palliative sedation, other opportunities. It doesn't have to be down the MAID pathway. And we'll discuss all of these with them as part of the conversation. And then it's important that there's a lot of misconceptions about MAID. So we sit and chat and discuss and answer the questions so that they understand the process. An assessment takes anywhere from half an hour to an hour or more. Sometimes it's not completed in one sitting because there's too many issues at play and we come back and reassess them. It is completed by either a physician or a nurse practitioner. Both are eligible to carry out the assessments and be providers. So this is the assessment form. Okay, it's on the same website, the HS MAID, Google, and health providers. It is 6 pages that you're necessary to do. It's easy to do, but there's some nuances to it that I just want to help navigate. It is checkboxes mostly. And as the IA, the independent assessors that one of you may choose to be if you don't want to be a MAID provider, and that's great. It's only 6 pages. The provider has a greater amount of documentation to do to meet some legal and medical criterion. But I'm only going to highlight what you may choose to be engaged in if you choose to do it, right? It's the demographics of the patient and your demographics. And the reason why your demographics are necessary is that the provider, when they submit things to the Office of the Chief Medical Examiner as part of the finishing up things, there has to be proof that 2 independent clinicians assess this person and deem them eligible. So that is the reason why your information might be there. It highlights when the ROR is actually there, was actually completed, when you did the assessment. And then there's a declaration that the provider has to show, to highlight, saying that they were independent. So we're not conspiring, we're not collaborating together and coming up with the same assessment. And we're declaring that in our documentation. Then we go through the criterion. The criterion being eligible for health services, the criterion being greater than 18, capable of making your own decisions, and that we made this, you made the decision, or we're deciding that they're eligible based upon a conversation or what they've expressed previously, and that the patient was given informed consent, and that we've offered the alternatives. Ongoing palliation, ongoing opportunities, and that they can withdraw consent at any time during this whole process. We categorize what their condition is, right? We affirm irremediable conditions that are irreversible and they're having suffering in some way. And it actually categorizes the type of suffering. And that's it's simple checkbox in that situation. And then we confirm through the documentation that they have a foreseeable death or not. And I'll talk a little bit more about that shortly, because the law changed. So it's beyond just foreseeable death at this time that people might be eligible for MAID. We confirm that whether or not they are receiving palliative care and how long, and if palliative care was not provided, if it was actually available, and whether or not they need any disability support services, and if they have received it, how long they've received it. So that's to mitigate that people aren't rushing into MAID without the adequate supports to look at alternatives, explore alternatives. And then there's an area for a narrative. And within this narrative, you highlight a little bit of demographics of what the condition is, and that your discussion might be with the patients. I personally, in my narrative, I include some objective markers of morbidity, such as the palliative performance score. Many of the patients in hospital have seen palliative care, so all the scores are there. You don't have to calculate it yourself, right? I discuss the family dynamics, whether family is supportive or not. And then I acknowledge that they meet the legal criterion for MAID or not, and that they can proceed under whichever track, which I'll talk about shortly, track 1, foreseeable death or non-foreseeable death, and acknowledge that I approve through the signature block. Okay, so it's not an onerous form. It's not a difficult form, and if you choose to proceed with doing that as part of the application, that is welcomed. If you need help navigating through the form, the navigators can help you as well, or myself. What an assessment that's in the positive will do is it leads to a decision tree, right? It leads to eligible versus non-eligible, and if eligible, the assessors are going to classify them as track 1, which is a reasonably foreseeable natural death. And the drafters of the legislation intentionally kept reasonably foreseeable as vague. So what does that mean? It can mean anywhere within a year, right? But ultimately it means that the trajectory is heading in a pathway towards natural death in a meaningful way. Okay, but there's no definitive time period that's out there. There is, as a result of the last iteration of the law, a track 2 of not reasonably foreseeable death, natural death. And it was meant, a lot of people disagree with this, and it's controversial, and then that's fair, right? It was meant for end-stage chronic diseases, or those that have disabilities and have chosen this pathway as a pathway for them. There's a lot of people that are opposed to this, and that's fair. And that is a part of our national debate of what that means. But not reasonably foreseeable death has some criterion that apply to it. So if you meet track 1 criterion, you could proceed with MAID at any time after the approval process, right? We need a day or 2 to organize things from a logistical standpoint. For our team. If you are track 2 deemed eligible, by two for the, only one of the two has to say track 2 and you can't proceed with track 1, right? So both don't need to confirm. As long as one person deems them track 2, the provider especially deems them not reasonably foreseeable, then the patient is mandated to have a 90-day period of reflection where they cannot proceed with MAID. So the clock starts with the first assessment, and then 90 days has to elapse before the earliest they can proceed. And what we've learned, honestly, that people that have sought out MAID, that have been approved track 2, many don't proceed, right? They just want the reassurance that they can, and they don't, right? That is the majority, but track 2 is out there as well. I want to spend a little bit of time talking about the waiver of final consent, because that applies to Darren's situation that you highlighted in the case. So where we recognize that there's an anticipated risk of loss of capacity, the provider, the person doing that second assessment, can complete with the patient collaboratively a waiver of final consent. It's a legal document that is an agreement to proceed at or before a mutually agreed upon date if capacity is lost in the time waiting. Okay, so it's legally bound between that one provider and the patient. So if something happens and that provider is not available, we can't proceed with the waiver of final consent. So there's legalese involved in it, but it is what it is, right? So an alternate provider cannot substitute in for the waiver of final consent. Nuances: unless you get involved in the team, you won't be completing the waiver. It's between the provider and the patient, and it's a lengthy document. With respect to provision, once deemed eligible, right, we can provide. So at a future time and place of the patient, we'll assemble a team, the clinician who's the provider, nurse practitioner, physician, and a nurse, because reality is we aren't good at IVs, doctors. And so we bring somebody along who is good at IVs. And so I don't know if you've guys seen the Sookram technique of IV access. So all our nurses that are part of the team are either seasoned Emerge, ICU, or NICU. NICU has made the best nurses. Adrian's here. Do you do your own IVs?
We're just saying that I think the last time I did one was at night on call about 6 years ago.
6?
And the staff were really, what the hell are you doing?
I figure when I have to do an IV now, they need a central line. If our nurses can't get, yeah. So we at a future time and place, we can proceed. The patients that are in hospital sometimes choose to have it at home, right? And we transfer them home. The reality of homemade, and I have this discussion with them, and a lot of us have colleagues that have discussions with them, would be that the survivors have to leave with the guilt that MAID occurred in the home, and it does leave a stigma that is troublesome to some. So some people choose not to have it at home. We have some designated neutral locations in the city that we can transport patients to. We haven't done hotels. I've done it in hotels, but we've transported them to neutral locations at the Cross, Norwood, certain outpatient settings, so Strathcona outpatient clinic, Sturgeon outpatient clinic. Any unusual places anyone else have used? Some people want it in their backyard. I've had it done in their backyard, surrounded by family. But we find the place for them, or they remain in situ in hospital, right? In hospital, thankfully, the system finds a nice quiet place that family can assemble, a private room, and they sometimes have to leave your ward to go to have that done, but we try to accommodate them as much as possible. So the two people are assemble. As part of the process, we confirm capacity and the desire to proceed, and we try to facilitate patient requests as much as possible. Some want their pets there. Some people want to wait for a family member to come from elsewhere. Some people, it's a variety of stuff. They want music being played. I've had some weird requests and we try to accommodate them. Unfortunately or fortunately, someone wanted a shot of alcohol beforehand, and so we try to accommodate them. One guy here sent his family member to go to the beer store across I don't know where the nearest beer store is to here, and then they brought back a beer and they all drank it together, and then he proceeded. You know, it's different. Do you have any weird ones, Adrian?
The beer.
The beer.
Thing, yeah.
Yeah. And they ask you to do it. And I'm always challenged by that. Like, what is the ethics behind having a shot with someone that's about to die? But it is what it is. What we need from you, ultimately, the team, is good IV access. And if there is not good IV access, then arrangements for a PICC line ahead of time. And then I think a very important part of our role there is supporting the family and the hospital staff. Our hospital staff are often of backgrounds that are very spiritual, and some take this process of someone they've cared for a period of time to heart. And I think it's important we all support them through the patient's decision. And so I try to acknowledge their work. I try to spend some time, and sometimes we have to have a debrief. I think we've made to be around long enough now that most of the hospital staff is aware that's happening. But in the early days, we had our navigators came and did a debrief with the teams because that was important for them to understand this. In a lot of the long-term care facilities, that's an important part of the process. What is the regime? It's a standardized protocol that's been in existence since 2016, laid out, but it's been available in Europe for the last 20 years. So we haven't varied it. It's supranormal amounts of drugs that we have used for a long time. So midazolam, 5 to 10 milligrams. I use 10 over 1 to 2 minutes. They're snoring, they're sleepy. Some require opioids concurrently, but rarely do I use it. If they're on high dose opioids, I do. But if they're not, we proceed with lidocaine, 40 milligrams, to freeze up the vein so that the propofol, which does hurt, for those of that have had colonoscopies or endoscopy, it does burn a bit before you fall asleep. It freezes it up, and then we use propofol 1,000 to 1,500. And that anesthetic dose is 200. So we're using supranormal amounts of propofol. And then rocuronium, supernormal. The intubating dose is about 100, so double the intubating dose given. And what is the process that happens? It varies based upon the person's morbidity and their physical state, but we often see midazolam making them precipitate amnesia, sleepiness, and snoring respirations. And the propofol, as it's being infused, and 1,000 milligrams is 3 big 50 cc syringes. So it takes a while to inject it and a lot of force. It creates a deep sedation and then terminates the cardiorespiratory status and coma. So by the time you're halfway through the propofol, you'll see discoloration of the patient, face and mouth, and coma developing. And then the rocuronium is given as well, even though more than likely they've passed away from the propofol. It's just that we follow the same protocol, and cardiac death will occur within 3 minutes of completion of the drug regime. So the heart stops, you confirm it by auscultation or ultrasound or whatever, and they have passed on. So as described in the reports to Parliament by, it's an elegant way and it works. So there's no suffering as far as we know and what the literature has shown, and it certainly will work. After death, our process is that the Office of the Chief Medical Examiner is consulted and all the documentation shared with them. This is important. The death certificate does not need to be filled out by the inpatient team. The death certificate is completed by the medical examiner, and they share it with the funeral home in the background. The remains of the individual can be transported down to the hospital morgue. Tubes and lines can be removed. The funeral home is contacted by either family or by nursing staff or by the MAID team, whatever is arranged ahead of time. And unfortunately, the discharge summary is your responsibility. So I apologize, but that's just the way it is. Some key messages my team wanted to make sure and highlight for you guys, because it has been a complicator that we've identified from a system standpoint is that the navigators are there to coordinate access to the assessments and provisions across the healthcare system in all sectors. So if patients move from your site to another place or long-term care, it just carries on. Our team is not just dedicated to here. Our team will go wherever. So as a result, MAID assessment and provision is not a disposition and should not delay discharge. You're welcome to move them to wherever you need to move them, and we will go to wherever they are. If they're going to palliative care, through palliative care to hospice, just let the palliative assessors know so that they can recommend sites where we don't need to subsequently do forced transfer at a later time, so it's a faith-based facility. And if an ROR is coming, just make the navigation team aware that the patient might be moving, but that be watchful for the ROR. And here's another part that addresses what we talked about. We are not an emergency consult service. All of us do this in addition to our other jobs. Those of us at the university site are also clinicians here. And so we've chosen to do the assessments here because it's easier because we're physically here more frequently. Our nurse practitioners and physicians are. If you need something done expeditiously, make it aware to the navigation team, and we can often get it done within a day or two, an assessment. And we have been able to provide MAID in an expedited fashion within a day, but it's not a common occurrence, right? There's a number of steps that have to be navigated through, in particular pharmacy. We've just gone through a pharmacy change, and they identified with just before that there's a fair number of conscientious objectors within their team. And so to acquire the drugs, sometimes we have to be very innovative. And we've used outside pharmacies to acquire the drugs in some other facilities within the city because of the pharmacists are conscientious objectors, and we're trying to respect that as much as possible. But that's a rate limiting step as well, going to get the drugs from an outside pharmacy and bringing them in. So we're not expectation. Reality is that we can do things within days. And so in your situation, the earlier the ROR was present, the easier it would be us to accommodate, right? I live 6 blocks away. My wife's also an assessor, and there's a number of us that live close by. I don't know if you guys know Curtis Rabuka. He's retired now, so he has a lot more free time now. Adrian's around when you're here in town. There's other people around that can get done. So where to find the information? As I identified on Google, you can put in MAID and AHS. The website is there. And there are resources out there. The Canadian Association of MAID Assessors and Providers, CAMAP, has a website, and it has a lot of resources on there. I'll talk about some of the educational opportunities in just a second here. So what's happening that you need to be aware of that's evolving in the MAID world and might be a complicator, confounder, is some patients are choosing to donate when they have a condition that donate organs, when they have a condition that they want MAID, but they want their organs salvaged, and that's called donation after cardiac death. We've utilized this often within the ALS patient population that have chosen this. And so in those situations, we bring the patient to the OR, perform MAID, confirm death for a 5-minute period, and then they get whisked into the OR quickly and are operated, and organ salvage occurs. So that happens. Patients have chosen to give anatomical donations, and we've been able to facilitate that now. So through the university's anatomy department, the body can be recovered and taken there. And then tissue, through the comprehensive tissue donation system, does exist where they can salvage corneas and tissue, and they come to wherever the body is to get salvage whatever organs they have. So those are reality, and we discuss that. And some patients want to make it quite clear they want to do that, and that's great. It just complicates the process a little bit from a logistical standpoint. Here's the controversial part I wanted to just highlight. What's under consideration in the next iteration of law. And I don't know how this is going to play out from a politics standpoint. I just want to make you aware that this is out there in the conversation. And I haven't figured out where I lie on it. I struggle with some of these as well as in my position. And I guess as our providers will have to struggle through this as well, of where their ethics lie, their personal ethics. Emancipated minors, these are kids that are under 18 that might have an end-of-life condition such as a hematologic malignancy. That's the population that is often applied there. But there are other people with chronic illnesses that are life-threatening. Pamela Wallen, member of CTV News, she's a senator, and she's been a big proponent of advanced directives. So those with cognitive decline, being able to, we haven't developed this, but a process where they can say, when I hit a certain stage and I don't have the wherewithal to give consent and capacity, I want to proceed with MAID. Other parts of the world have that process in place, especially in Denmark, in Holland. I was going to say Dutchland, but in Holland. How it plays out, we don't know yet. And the most controversial, most recently, is mental disorder as a sole underlying condition. This is a challenging one from an ethical standpoint. I personally think there's a small percentage of people that might be eligible. And this, in my opinion, are the person that struggled with depression refractory for 30 years, the schizophrenic that has such bad side effects with their medications for many years and have struggled. That's what it was meant for. And Paula Simon, our local senator for Alberta, has been a big proponent of this. The lobby groups have gotten involved in this, and it's much more diverse. And where it lands, I have no idea. So we'll wait and see where the legislation lands on. It's dependent upon the politics and the legislative process. So the navigation team can be reached through this phone number. If patients want to reach out themselves, they can either call that number. It's monitored even on weekends. Okay, so it's there, or they can call 811 and they can be transferred, or the information be given through 811. For you to send your RORs in from the floor and or your independent assessments, there's a fax number there, or you could email it to that email address there, and that'll be on the presentation. So educational opportunities for our learners and our clinicians that are out there. There is a national curriculum that is being developed that is a great resource on how to carry out the assessments, how to weigh your own ethics into this, how to handle difficult situations. I think there's up to 10 modules now that are all CME accredited through the CCFP or the FRCP, so you can get your hours. They're often done hybrid, so online with an in-person opportunity as well, or Zoom virtual opportunities. So that's on the CAMEP website, and their website's there. And if you're interested in being an assessor or provider or need more information, please feel free to reach out to me. And we don't just throw you into the system. We'll give you time to do some self-study and self-reflection. I personally encourage you to do the national curriculum, at least on the assessment process. And we will provide mentorship and guidance, buddy shifts, and or help you through the process. And you don't have to do provision and assessments. If you only want to do assessments, which some people do, that is perfectly fine. And stay away from the provisions. We will tailor it towards what your personal ethics are. Right? No one's going to force you to do something that you don't want to be involved in. And what MAID has done, honestly, in my own involvement, has given me a personal appreciation of life. And I've taken my involvement to go and do stuff. I value life. And so we travel a lot as a result of my wife and I's involvement in MAID. And these are some of the highlights. So the top one is on Moorea in French Polynesia, which I was at 2 years ago. And we were just at the Taj Mahal last month for my 20th wedding anniversary. So there. And then through my military activity in the past, I traveled around the world doing stuff, getting into mischief. But MAID allows me to appreciate that. Life is fragile, right? Life is short. And so you need to seize the day. And who knows what tragedy awaits each and every one of us at some point, potentially. And when you least expect it, go do stuff. So for our learners out there, please go do stuff. Go to work, but then go to do your stuff as well, right? Yeah. So please, I entertain questions and controversies, and I look forward to anything else. So I left enough time, I think. Yeah, Adrian.
So Neil, the government put out a consultation on some pretty radical changes to the MAID system.
Yeah.
Haven't heard anything about the feedback. But talking to Jim Silvius, he thinks there's going to be an attempt to radically change Alberta's system, which is nationally, I think, one of the best systems. Have you heard anything?
I was at the conversation where they seemed to force feed us, right? The pathway. I think what they're going to do, in my opinion, is some of the things that Ontario has with respect to a review group that reviews all the cases, that will happen. But the legislation is national. It's not provincial. So it will continue to happen. But I think there'll be some more monitoring. I haven't seen what's coming. I mean, the reality is, I don't know who's here.
There are proposals about families having access to applicants' medical.
I agree, and I haven't seen that meaningful work towards that. There is an element of lobby group within Alberta, is that the political way of doing it, that are very spiritual and are pushing their agenda. Where it comes out at the end, I don't know yet. Yeah.
That was really great. Thanks for that overview. So I had a question about, and particularly this case, is once you get approved, how long does it last for? Because there's so much uncertainty. Imagine, could this patient have done it like 6 months or a year prior?
Yeah.
Recognized at any point in time.
It applies. We use a bar of about a year, right? If a year has lapsed and you've been approved, we need to touch point with you again. Right, so we have extended it up to a year in the track 1. Track 2 mandates at least a 90-day wait period, and then it goes on for a year. If you apply, 6 months or a year has lapsed after that 90 days, and you then want to proceed, someone's going to do a touch point with make sure you're still eligible. Yeah.
I'm going to ask Dr. Lau to ask his question now.
Sure. Thanks for that talk. I think you touched on a number of the trouble points that I encountered in the case, including the ROR being the rate limiting step. That was actually quite a significant barrier. And it's interesting. I remember when MAID initially rolled out, there was a waiting period, a cool down period. And so I had a misconception there, but then that cool down period went away, and the patient and your community provider took the wrong message from that. They took the message that, oh, there's anytime on request, which is not true. You have to initiate the legal process. There's still a legal process. And the funny thing is, I dug trying to find the information about this during the case, and I found the AHS website very difficult to understand. And I didn't find a very specific flow pathway from the other websites. And I was just wondering, first question, if you could comment on any ways we can improve education about this for our patients.
I think that if people are interested in MAID, right, direct them to the navigation team. They will walk them through the whole process, outline everything. There's 5 of them, right? So they will talk to family and friends, family and patients, and then highlight all the important things. And it's manned 7 days a week, the phone number, right? So the assessment might not occur on weekends, but there's someone answering the phone during business hours all day.
Sorry, just in follow up to that, does that mean you can refer to the navigation team without submitting ROR if they just want more info? Yeah. Yeah? Oh. Yeah.
They'll navigate it through. Yeah. Okay. Yeah. That's the key. That they are all skilled. A lot of them are ex-emerge nurses, so they get it. And so they will help the patient through it. Okay.
Because poor Darren, the patient was admitted Thursday, and then it was the weekend. No way that's
but the patient can call. Yeah. you can call and we can, and tell the patient, this is what we need. The RR needs to be filled out. We'll get Dying with Dignity out there if we need to. It can all be organized, right, to help them navigate through that. And then we start the process.
That's
Yeah.
good to know that resource exists.
Mhm.
My other question is to follow up on one of your points about capacity. And so if this patient had survived on Monday but was delirious, could MAID theoretically have been offered?
So if the assessments were done and they had a trajectory towards loss of capacity with delirium, the provider would have completed a waiver of final consent. And if that was in place and the provider was available, they could have. Now, our capacity expert is Adrian. Whereas questionable capacity, we call out to one of our providers that, or assessors that have expertise in capacity assessment and ask them to determine that. So that is one way of navigating that. But there are times, fortunately or unfortunately, patients don't meet the capacity criterion and we do not proceed.
We do try and facilitate capacity as much as possible, either in time or situation, or as Sunil said, go back, because domain and time specific, you want to facilitate where possible.
So.
I think, yeah.
Yeah, I know we're limited time, but I will start with my bias. I am opposed to MAID, and actually I do talks for Christian medical students, and I've actually been invited to faith-based high schools to do talks on this topic.
Hmm.
And when I've reflected on it, and this is a good example, there's nothing in this talk that talked about the why for MAID. And you said this, that MAID is the outcome. Well, no, relief of suffering is the outcome. I agree the cross should have initiated the ROR right away. Even though I'm opposed to it, that's due process, should have been done.
Mhm.
But when they come in at this late stage, I would have hit this person hard with opioids, aggressive palliative care, that probably would have ended their life, which is congruent with palliation. And I find time and time again, the ability to respect physicians' conscious objection with a team, which is great, leads to too many physicians going, consult MAID and walk away,
Yeah.
as opposed to having the hard discussion with the patient, what do you need now? And I've been involved with a lot of these cases, like you said, but you actually spend the time with the patient, they're like, oh, I didn't know palliative care would do this.
Yeah.
So I just want to encourage people, I would never subvert the system, I still follow the rules, but just spending time with the patient, understanding what they need has made a huge difference in most of the cases that I've been involved.
I agree with you. I think whatever the patient's values are, we need to respect, but they need to be presented with the opportunity for increased palliation of symptom relief and go down a pathway they choose to, right? Now, some people choose, this is what I want, that's fine. But maybe that once presented with things, they will choose otherwise. The challenge you and I know, or all of us know, in this system of overcrowding and the one-to-one conversation opportunities being lost, that's not happening. Yeah, and that's unfortunate. Yeah, our palliative care team, I don't know, is there any palliative care docs here? They too are stretched, right? They can't do the hand-holding in a hospital that they used to be because there's so many people they're engaged with. That would be great if they could continue to do this, checking on them twice a day and topping up and fine-tuning the process as the patients stay progressed, but that's not the care. And outside of the hospital, palliative care is almost non-existent. And that's really sucky, right? And family doctors are not getting into, I'm dual trained, both family and emergency medicine. I think comprehensive family medicine and the hand-holding in those final days is so important, but it's not happening.
And the thing that hits, this woman was dying 2 years ago, she had bone and ligaments.
Mhm.
Why is Darren having to deal with this at 2 o'clock on a Sunday morning? You know, she should have had a really good plan in 2024 to say, you know, how do you want your death to look? Or,
That conversation is an important one. Who has it? We've learned, or at least I've learned from my 25 years of experience, the cross doesn't have it.
usually to the Centre for Dialysis.
Because they feel that well, my friends, some of my friends are cross docs, right? They say that conversation is discouraged because it takes away hope. I don't know if that's right or wrong as an argument, but I think that's an important part of the cancer conversation. But I'm just a lowly emerged doc.
Okay, well, I think we're at time, and I want to thank Dr. Lau for bringing the case forward and Dr. Sookram for an excellent presentation, and all of you for your great questions. Such a good discussion in the room. Thank you so much.
Thank you very much, everyone.